what ideas would you want to contribute that you feel should be considered in the development of the federal framework? And we want to give you and dedicate the entire morning for you to work on this. And then at lunch, we'll have the facilitators, the note takers, get together and try to get all those ideas so at 1 o'clock we can bring these ideas in the room. And while you won't have a chance to comment on what they're going to say this morning because they were just key messages from yesterday, this afternoon when they come back with ideas that you've proposed, we're going to put them on the table. And if you were not in surveillance and Alain shares the results of the work in surveillance and all the ideas are going to come out, we're going to give you the opportunity to comment on them. And to add, especially if you weren't in the group. If you were in the group, your ideas would obviously be considered. So we want to give you the opportunity today, this afternoon, especially after lunch, to really comment and add your own. So that by the end of the day, there's two things that are clear. One, the ideas that you heard that you think should be part of a federal framework, and two, or should be considered to be part of a federal framework, and two, where does this process go from here? How's it going to go? And we're going to hear from the tri-chairs at the end of the day. Dan, Jim, and Greg are going to share with you as tri-chairs where this process goes from here. But you know, in the discussions that we've had so far, on Sunday night, yesterday, when you're in a big tent and it starts to rain outside, you rub elbows, and sometimes, that creates a little friction, but it's about being together. It's about finding a way to work together. In the international work that I've been privileged to do, trying to help various populations fight tough diseases, there's a very interesting African proverb that I would invite us to be mindful of today. And it goes like this: alone, we can go faster. Together, we can go further. Alone, we can go faster. Together, we can go further. Seuls, nous pouvons aller plus vite, mais ensemble, nous pouvons aller plus loin. Let's be mindful of, there's a whole bunch of us involved in Lyme disease who really can play a critical role. How are we going to leverage the best of all of us to be able to create a framework that's going to address Lyme disease the way Canadians deserve to have Lyme disease addressed in one way, shape, or form? Today, essentially, is our day to do this, to generate the best possible ideas that can create the best possible framework. All right? That's our task today. So without further ado, let me invite Alain Rabot to share the results of surveillance. And before we actually go, I'll share a few other administrative messages with you. Alain?
Merci, Daniel. J'aimerais remercier les gens qui étaient, évidemment, qui faisaient partie du groupe sur la surveillance, mais particulièrement nos 4 conférenciers hier après-midi, Nick Ogden de l'agence, Natasha Rudenko, qui est de la République de Tchécoslovaquie, Vet Lloyd de l'Université de Mount Allison et Curtis Russell, qui était de l'unité de santé de la province de l'Ontario. Les présentations étaient quand même assez percutantes, puis je pense qu'on va continuer à en discuter au courant de la journée cet après-midi, même que je vais inviter nos participants qui font partie de l'atelier de continuer à considérer ce qui a été divulgué par nos conférenciers hier. Surveillance was the topic, and you can imagine with all four of our presenters, we saw a lot of maps, a lot of risk maps. And what was a number of key messages emerged from our conversation after the to and from with questioning, to and from of discussion amongst ourselves. And one of the key messages that came out was that risk maps have to be continuously updated. Understanding that there's a lag between data collection and producing of the map, the more that we can shorten that span, the better and more useful those risk maps are. We also stumbled across a really important and interesting fact, is that we now recognized from our conversation that some of these risk maps are being used inappropriately to determine testing, diagnosis, and we had a very compelling point made that these risk maps are also being used to deny insurance coverage in some instances, which was a bit of a for me anyways, and I think for a number of people around the room, a bit of an aha moment. We also recognize one of the inherent limitations to surveillance data, and what one of the participants coined as the lost in translation factor, which is we lose some of the importance and meaning and utility of the surveillance data as it goes from scientists to medical staff to general public to informed public such as you and so on. So there is that factor that we have to bear in mind that also has some implication, of course, for the awareness and education group. One of the presentations from Dr. Lloyd was quite telling, and I think also drove home the point where the leveraging, I've kind of tagged this and encompassed this under leveraging community involvement in surveillance. That's the headline, if you wish. But what was really interesting in the conversation, because many of you already do surveillance on your own, there's huge advantages to broadening the data that's gathered. And Dr. Lloyd also pointed out the huge corollary effect that this has in terms of raising awareness in local communities. As you're going out collecting this data, there's huge awareness that can be built inherently in that. We also had some conversations around community involvement, around the need for precise methodologies and so on, and also raising concerns or the preoccupation around safety of those that are also doing that kind of surveillance. So those were part of the conversation. Around the dissemination, and I'm going to coin this, and this is my own term, and it may be somewhat lacking, it's the granularity of the information. And this spun quite a bit of conversation. Jim, you were certainly part of that conversation at one point. There's a need to have information that is precise enough that allows us to make informed choices, allow communities to make informed choices. And the example we gave is to put a prevalence or an infection rate of ticks at a provincial level is quasi-meaningless. We need more granular data to make those informed choices. Which was also one of the conversations, and Dr. Lloyd, again, was the one to bring this up, is that the Centre for Disease Control has a model that is used in terms of breaking down that information to a regional level that perhaps we could use and inspire ourselves with or by to use that kind of information, that kind of data. So that was another key point that was raised. As with, I suspect, the other two breakouts, the surveillance breakout felt absolutely necessary, on dirait en français, d'aller jouer dans les plates-bandes du voisin, to go play in the neighbor's backyard. And so we talked about education and awareness as well in our conversations. There's two things that came up, and it was very much driven from the conversations that we got following Dr. Russell's presentation around the role of public health units in Ontario in particular, and the role that they have in terms of informing the Ontario public. So we talked about signage, the need for signage, and so on. But we also talked about the need for culturally adapted information. Ontario, and Canada for that matter, being as diverse as it is, we need to have that information transmitted and available that in a way that's reflective of our local communities. One of the points that was also raised that generated a fair amount of discussion was that our surveillance system is really driven by the collaboration between the provinces and the federal government. And this highlights the need for ongoing, systematic surveillance efforts in all provinces. So that, I think, is a point that was not lost on the folks. Yep. I have three more points to make. Underlying all of this conversation was a need for more resources dedicated to surveillance. That was clear. We also poked our fingers at a couple of gaps that we see in surveillance, particularly in keeping track of those that have contracted the disease. One that came apparent is those that perhaps contracted the disease outside of Canada, have come back to Canada. Are we tracking? Are we aware, particularly in the events prior to this being a notifiable disease in 2009? That was part of some of the gaps, and I have no doubt that there will be gaps that we'll further explore this morning. Finally, last point, Dr. Rudenko's presentation, she's from the Czech Republic, and highlighted the breadth of tick species that they are studying and monitoring. And my numbers may be slightly off here because I'm going from my own handwritten notes. She indicated that worldwide, there are about 10 different species that are involved in the transmission of Lyme disease. And I think that in our conversation in our room, that sparked a lot of discussion around the implications that this has for us. And we haven't landed on that conversation. I suspect that will be a recurring theme over the course of this morning, but certainly Dr. Rudenko's presentation was, as we say en français, très percutant, quite impactful for us. So I hope that I've done justice to the topic. I know that I will likely be open to criticism from the good folks that will be working with me in the surveillance breakout. I will be happy to respond at that point. Thank you.
Okay, let's have Lisa Babi now talk about guidelines and best practices. And given that you worked with about 150 people to gather all that, that's a challenge. But good luck.
Thank you. No, I'll just ask all 150 people to each say, no, we're not going there again. All right. So good morning, everybody. What I did for this report, contrary to Alain, I didn't try to go through the whole afternoon, but I focused on the key messages that were raised at the end of the afternoon by the participants in the session. And I tried to organize them in a way that kind of eliminated duplication. And remember, I promised that I wouldn't include the recommendations, that I'd focus on a description of the current situation. An introductory comment, I guess, that I would make is that it's pretty obvious, and if I do my job right, there will be no surprises in what I say here this morning. If I did it wrong, then I might be asked to leave the room. There are different stakeholder groups in the situation that are all coming at this situation from a completely different worldview. They're looking at it through a lens that makes them interpret what they see differently. And they also have different interests and different needs. So I thought what I would do is frame the key messages within those groups. I've identified 3. There are multiple others, but we really focused on 3 of them. And before I get into the human groups, some of the key messages were about Borrelia itself and the disease. So messages like Borrelia is not a typical infection. It's a complex organism. It changes over time, and it can't be cultured. And that makes studying it, working with it, healing it very, very difficult. Co-infections are not well understood. Other modes of infections than ticks, and Alain just mentioned the multitude of tick species as well, are not well understood, need to be fully discussed. And there are other ways of getting the disease that don't involve ticks, and what do we know about that, and what are the questions around that? And then again, to complicate things further, there are other tick-borne infections that mimic or that cause Lyme-like symptoms, and that's also a source of confusion and difficulty in terms of really understanding what you're dealing with here. Key group, obviously, are the patients. Patients and their families want to be heard, and they want to be included. You have a sense of urgency. You need relief now. And the burden of cost you feel is squarely on your shoulders. Most of you are willing to help with research, at least that's what came up in the session, to participate in clinical trials, to give blood, to do what it takes to fix this. You're intelligent, you can understand the risks and work with your doctors on the best solutions for you. There are a lot of differences between cases, even if there are similarities. And there are also different needs at different stages. And that might be tied to how the Borrelia actually morphs over time. And the real issue seems to be in the later stages and the confusion that there is around all of that. There was emphasis on a holistic approach and the importance of paying attention to things like diet, lifestyle, alternative practitioners, other things that might influence your ability to get well and stay well. And then concerns around Lyme disease not being recognized as a disability, and the fact that the disease just causes excessive strain and emotional impact, and that you need validation and you need emotional support. Researchers want to do good. They're not here to make people's lives miserable. They have a constraint that the science they do has to be evidence-based. There are questions, however, around what is evidence. And there are some who feel that the definition of data might be too restrictive. You talked about qualitative data not being considered enough, and that has to be balanced with enough rigor in how that information is collected so that it can be used as evidence for science. And remember, there was that conversation around there's so much information, so many experiences, and they're not being used. And why is that? Because we're not being systematic about capturing that information in a way that science can use it. So there's a real opportunity there, is what I heard. There is promising research being done. It tends to be happening in silos, which is an issue, and it's obviously happening too slowly for those of you living with Lyme disease, so finding ways to balance those needs again. A combination of drugs seems to be a promising approach. We heard about research that shows that really good results in vitro research, and now the next step is, so how do you further that research so that it can eventually lead to conclusions in humans? A concern among researchers, and should be a concern, was suggested for everybody, which is antibiotic stewardship and resistance. So, the risks of pervasive use of antibiotics, and not just from a resistance perspective, but also on the health of people who do use antibiotics for a very long period of time. Clear that we need research on diagnostic and testing, not just on treatment, and that we need interim solutions on both while the science advances. Okay, one last topic, the doctors. Don't want to forget the doctors. They want to do good too. There's a need for more Lyme literate doctors able to treat the disease. There are issues with the current clinical guidelines that constrain their ability to do good. The guidelines are not flexible enough. They overly constrain the freedom of action. Doctors need to be allowed to practice, was one of the ways that this was said yesterday. The guidelines focus on the eradication of infection when functional improvement should be the goal. They're effective in the early stages, but not at later stages. There seems to be a clear distinction there again. So there's this evolution over time theme that seemed to come through yesterday afternoon. And the whole issue of the two-tier testing approach, which is only effective in a small minority of cases, and diagnostics not being accurate at 100%. So hopefully I captured what you said. I'm sure there's so much more out there, and as Alain, I'll be here later this morning so you can tell me all about it.
All right. Thank you. Let me invite Kathleen Connolly to talk to you what happened in education.
So we had a very passionate and, if I may say, brilliant group yesterday. Both the participants and
Are they here this morning?
I think that I see many of them. Both the participants and the speakers. So thank you. So we also ended up talking a little bit about some of the themes in the other groups, but I will just focus for this report on what related directly to education and awareness. And I've organized this in two parts. One is sort of messages in general about education and awareness, and the second part will be some of the messages we thought would be important. So, in terms of general messages, les messages qui sont d'un ordre plutôt général, there's a patchwork of poor information out there. There's a lot of misinformation. There's conflicting messaging. For example, the length of time a tick is attached to a person before it causes harm. So what we need is persistent and consistent information is an expression that was used, and across the country, consistent across the country. There's real stigma attached to this disease, and we're going to need sort of good ethics in communication to address that stigma. The focus is too often only on acute infection, and we're going to want to make sure that we consider the chronic aspects in all of our efforts. Messaging has to focus on prevention, so oublions pas de mettre l'accent aussi sur la prévention. And we must evaluate results like, are people changing their behaviors as a result of our information, education, and awareness efforts? And then we also talked about how it would be good to actually kill the little critters before they do damage. I edited the wording there a little bit.
It's a cleaned up version compared to what I saw.
So, key messages relating to how to reach and the whole issue of the state of awareness of physicians and health professionals. They're not well educated in this area. We've not been doing a good job at reaching them. We have to start in the medical schools. And the importance that education has to include the notion of the importance of patients and patient preference. And then physicians not only are not always well educated in this area, but they don't always have the information they need, which we've heard a bit. They're not, for example, aware of diagnostic criteria. They think that only the textbook rash is an issue. They don't know which test to order. These are just some of the examples we talked about. We need to ensure that they have easily accessible, up-to-date information to make a clinical diagnosis. Many physicians don't even know if they're in an endemic or high-risk area, so that's where the surveillance activities and communicating that to them becomes important. We can't just focus on physicians, but we have to focus on all kinds of health professionals, paramedics, pharmacists, nurses. Il faut vraiment inclure tous les professionnels de la santé dans nos efforts de sensibilisation et d'éducation. So to reach physicians and health professionals, we talked about a variety of ways: newsletters, guides, reference manuals, exhibits at really well-attended conferences, webinars that provide credits, use of apps, among a few. A specific idea that was mentioned was maybe including some education about this in, how we have to renew our CPR as health professionals. That would be one way. A good example of one way of doing it. And then we also heard an interesting initiative, the Lyme course, which are students and residents that are trained to get the messages out about Lyme disease. These are just some specific examples that were raised. When it comes to the general public, public awareness is low, and we need a cross-Canada mass media campaign, that uses all the different multiple media: TV, radio, internet, social media, signs on trails, signs in summer camps, at the Y's, just some examples, but something that really is across the country and age appropriate, of course. Using comics was an example that was shown for kids. So we also talked then about messaging itself, and I'm just going to give you a little idea of what came out there. For physicians, the messaging has to include, it's got to be about tick-borne infections and co-infections. It has to include messages like, you got to be suspicious as a physician. Don't rely or wait for the test results to treat. That was a key messages from the group. Treatment must be individual and evolve with the disease. Use combination therapy. Don't give up on your patient, were some messages that were relayed. And then for the public, of course, it would be what you expect. They need to know, how does transmission occur? What Lyme disease does to your health? What are some of the risks around it that are associated people are not aware of? How to protect yourself, how to remove ticks, what to do if you think you might be infected. So in a nutshell, education and awareness has got to be everyone's business. C'est l'affaire de tout le monde, la sensibilisation et l'éducation. If we're going to do well here, we all have to take responsibility, was one of the key messages from our group.
Good.
Voilà.
Thank you very much. Merci beaucoup. Okay, a few critical announcements. Many of you have said, look, this is a great presentation. How can I get a copy? All presenters will be asked to share their presentation. Some will say yes, some will say no. Those who said yes, somehow the Public Health Agency is going to make these things available. We don't know the medium yet. We've got to look at, is it the cloud? Is it the, whatever. But to make them available to you. They might send them to you, whatever. They'll figure it out, but the idea is that we're going to try to make as many available as possible.